All right. First of all, I'm Dean Melton. I'm the Director of Addiction Programs at Wake Forest. We primarily run an intensive outpatient program. But I'll give you a little background. I've been doing addictions work for 30 years. I've had the privilege of working with Dr. Brown and Dr. Gligorovic for quite a while. And I just want to say this. My feelings have been hurt a couple of times recently by both of them. Okay? And I just need to say this out loud to get it off. When I was sitting in the general direction over here near Mr. Ben Bentley, when Dr. Brown was saying all these things about this nice, wonderful person and sweet and kind and wonderful colleague, and he was looking in my direction, and I thought he was talking about me. And then he mentioned Dr. Gligorovic's name, so you've really hurt my feelings. I want you to know that, okay? And then Dr. Gligorovic, he came to my office one day and said, "Would you be willing to talk at this presentation?" And I'm like, "You want me to go half a day?" And he's like, "No, I do not think you're intelligent enough to talk that long." So, anyway, so I have an hour or 45 minutes or whatever it works out to be. To give you some background, I am not in recovery. As I said, I've been doing addictions work for 30 years. I've been to hundreds and hundreds of 12-step meetings. I try to practice the principles in all of my affairs. I love doing addictions work. I've had colleagues in the past that have said things like, "I don't know how you work with those people." And I'm like, "What people are you talking about?" And they'll say, "Well, you know, those people that are drug addicts and alcoholics." I'm like, "Well, yeah, what do you mean by that?" "Well, they lie to you." And I'm like, "Well, your patients don't lie to you?" And they're like, "Well, yeah, I guess so." And then they often want to know why, when they walk by the doors where we're doing therapy, why we're laughing and having a good time and sharing food together and different things. And I'm like, we're not a glum lot. We have a wonderful time. And it is truly a privilege to do this kind of work. It's, as one of my colleagues says, it's like often stapling Jell-O to a tree when you're trying to work with an alcoholic or addict, particularly early in sobriety. But it's truly a privilege. It's wonderful work to be able to do. I am very, very prejudiced towards the idea of working 12-step programs. I believe in that. I don't think that's talked about enough. So when I'm speaking, if you don't believe in that or don't feel that that's that important, that's perfectly okay. But I want you to know where I come from with this. We started up I've worked inpatient and outpatient. And I've been at Wake Forest for almost 20 years. They haven't found out that my diploma's fake, that they mailed it to me and all this stuff. So anyway, so I'm going to talk about intensive outpatient programs. And I guess I have to use this. There we go. There's my disclosure. All right, so these are just some of the objectives. All right, I don't need to read any of that stuff to you guys. Okay. The state of North Carolina has some definitions for how they define different types of treatment. An outpatient can be group or individual, and that usually occurs once a week. It can be as little as 20 or 30 minutes, or it can be an hour or two. Intensive outpatient treatment typically has to occur at least 9 hours a week, and it has to occur at least 3 days per week. Now, how you do that? You can meet 5 days a week. They don't care, but you have to meet a minimum of 9 hours a week. Partial hospitalization programs are 20 hours a week. Often they're 4 times daily, about 5 days per week. And then you have inpatient. And our typical inpatient stays. Is there anyone here from Fellowship Hall? No Fellowship Hall people? Fellowship Hall, I think, I'm not trying to sell Fellowship Hall, but I've had a relationship with them. I know Mike, the director. Everyone I meet that tells Mike that knows the director at Fellowship Hall, I say, next time you see Mike, tell him you met the man who taught him everything he knows. So I met Mike when he was first trying to break into the field, and he didn't even have a bachelor's degree, and he went back to school and got his bachelor's, his master's, and just kept working. But Fellowship Hall, a typical stay there is around 14 to 20 days. They like to keep people 28 days, but it's difficult these days in the managed care area. It's not inexpensive for people to go off to inpatient treatment and stay. And therapeutic communities are where individuals can go and live sometimes up to 2 years, and they often work. We had a gentleman in our department, a resident. He's an incredible man who was shooting heroin, not while he was with us. He was shooting heroin multiple times a day while he was in his 3rd year of medical school. Okay, and he, when he tells his story, it's really powerful. He said, "I wanted to be caught." He said, "I couldn't tell on myself." And, he had very close peers in medical school, and he said, "I finally told enough people that one of them had the courage to go and tell on me." And, of course, they encouraged him to seek help. He left medical school, and he went to a place in Sumter, South Carolina, and he stayed for a year. And he said, "I worked. I dug ditches. I did anything I had to do. I went to 12-step meetings. I got treatment." He got sober, came back to school, finished medical school, did a residency with us, did a fellowship in Emory after that in addictions. And if I'm correct, he's still in New Orleans, and he's the medical director over a couple of programs there and has been for a number of years. But therapeutic communities are where you can go and live and stay for a while. The last thing I want to say is 12-step groups alone are not treatment. One of the most common things I have people ask me, they'll say, "Are you holding 12-step meetings upstairs? You got them AAA meetings going on?" And I'm like, well, we do invite AA in, and AA and NA come to our facility and they hold meetings. But what we do is we provide treatment. And a lot of my patients will say, "When I finish this treatment program, can I just come back here for aftercare and not go to AA?" And I said, well, my preference would be that you not do that. This is where we do treatment, where you are going to continue to work your recovery program and begin that process of carrying the message and giving back and sponsoring people is in your 12-step meetings. And that's different than what we do here in treatment. Okay. Some of the criteria for outpatient programs is we want people to be medically stable. So, one of those simple things, Dr. Brown alluded to this, is if someone has a history of delirium tremens, they have a history of seizures, very often they are not good candidates to go directly into outpatient treatment because according to what they're using and how much they've been using, they may need to be at a medically managed level of care. But most people are medically stable. They hopefully are psychiatrically stable. And one of the advantages of working at Wake Forest is I have direct access to a number of psychiatrists, and we can get people on medications if we need to. Use a lot of psychotropic medications, mood stabilizers, SSRIs, SNRIs. Another one is the living environment has to be conducive to sobriety. Now this may seem obvious, but it's amazing that I have a young man right now that has a roommate, and every night his roommate and 3 or 4 guys are sitting around all night long smoking weed. Now he's living in that environment right now, and he's starting to have this revelation that possibly that's not the best place for him to be living. But when he first came to us, he said, "Oh yeah, man, it's cool. I can live there." And he said, "I just won't smoke weed." What he was doing, though, was he was eating gummy bears with, THC. I'm sure you look like one of those people who eat gummy bears with THC. Okay. All right. Anyway, so they have to be in an environment where they can get sober. Okay. Another one I often give is, if the person's living in a crack house, they're probably not going to get sober in an outpatient program while they're still living in a crack house. Simple. Makes sense? Okay. And the last one here is a willingness to establish a sober support network. That's a short phrase to say that people are willing to start going to 12-step programs. They have the ability to get back and forth to 12-step programs. We also want them to get a sponsor rather quickly. If you're not familiar with what a sponsor is, that's someone with some sobriety that the primary job is to start taking that individual through the 12 steps. Okay? All right. This is just something, I wanted to show you some stuff here from the National Institute on Health to prove that we're legitimate, maybe. Compared to inpatient care, IOP services have two advantages. One, we usually can keep people in treatment longer, 6 to 8 weeks. Okay? And that's a lot easier to do. And we get a lot of people that step down from inpatient treatment to our intensive outpatient program. So Fellowship Hall, for example, will often refer people over after they've completed anywhere from 14 to 28 days of inpatient treatment. And then they'll be in our IOP program for about 6 weeks, coming 4 nights a week. And it's a really great transition. But increased duration of treatment. And this is what I consider to be the biggest advantage. When I used to work in an inpatient facility, I worked inpatient for 8 years. I think we did really good treatment. And we would have these ceremonies, we call them coin ceremonies, and we would have already done our discharge plan, talk to our patient. And in our coin ceremonies, that's where we'd all get to go around and say nice things about that person and wish them well, and they would leave us and stuff. But we would always say, when you get back home, you need to engage in going to AA there. And we'd already have a schedule for them and all this kind of stuff. Biggest problem is a vast majority of people that leave inpatient treatment when they return home either only go to 12-step meetings a couple of times or they never engage. And some of the data out there shows that individuals who get, doesn't matter if it's inpatient or outpatient treatment, if they do not engage in ongoing 12-step, some kind of ongoing recovery program, with 12 steps being the most well-known, do y'all know what the relapse rates are within a year for people who go through a treatment program successfully but do no ongoing recovery processes? Somebody be brave. 40%. Extra month of treatment for you, Jerome. What'd you say? What's your name, sir? Tommy is correct. Give him a high five. He needs a high five. Okay. All right. So the relapse rate within a year for most people who finish a treatment program successfully, does not matter if it's inpatient or outpatient, is 90%. 9 out of 10. If you want to read some stuff about this, one of the best people to look at is a guy named Terence Gorski. He's kind of the relapse guru, prevention specialist of the universe. He's incredibly boring to listen to, not nearly as dynamic as I am. But anyway, he talks about this very clearly. Do you know what for people who get out of treatment and continue to engage in recovery processes, such as going to 12-step programs 3 times a week and getting the sponsor and working steps, at the end of a year, what percentage of those people are still sober? He gives a wide range, and I split it in half, but he says 40 to 60%. So I just say about half of those people are still sober. He goes on to also clarify that because somebody has a using episode does not mean that they failed and that they're back in active addiction. What he talks about is, I've gotten out of treatment, I'm working a recovery program. We'll use this word, I'm not crazy over it. I have a slip. I go out and use for a day. I call my sponsor, I talk to him about it, I go back to my AA meeting, and I get sober and I continue working it. Terence Gorski still considers those people to be sober at the end of a year. Does that make sense? Did that clarify? Okay. All right. We talk about psychosocial treatment is recommended in conjunction with any pharmacological treatment. I may step on some toes here. I've already told you I'm very prejudiced about treatment. Part of that is it's what I do for a living. It's a security thing. We have to make money to make a living, don't we? But what we're watching these days is we're watching a lot of medications being prescribed, particularly buprenorphine, and it is a harm reduction type of process. I love buprenorphine and I hate it. I'll tell you the 2 reasons if I remember. But we're watching so many people start to prescribe it without any encouragement of individuals engaging in therapy. And we think in the addiction field, as the use of the chemical is but a symptom of the disease. Use of the chemical is not the disease, it's one of the symptoms. And when I treat addiction, I always tell my patients, we could use the word bubble gum for whatever drug all of you use. I don't care if it's pot, pills, crack, coke, meth, heroin, I really don't care. I know there's differences in how quickly people become addicted to certain chemicals, and the opioid receptors are vastly more of those in the brain than there are of any others. The THC receptors are large too. But what I'm getting at is we treat the brain process of addiction. That's the disease going on, okay? And if I'm using alcohol and I want to switch to benzos, my brain doesn't really care. My limbic system doesn't care. My frontal lobe, that once I've developed addiction, it shuts down when I'm triggered, whether it's by using or seeing a picture or walking down an aisle in the grocery store. Once that gets triggered, I don't know that happens, and I have no control over that. That's a physiological and medical explanation for part of that loss of control process. Okay. Next, goals of psychosocial treatment for opioid use disorders is we're trying to modify the underlying processes. We do a lot of stuff about patients will come in and say, like Dr. Brown was talking, I'll use that example. How am I ever going to go down the aisle in the grocery store that has beer on it anymore? And we talk about how they can do that eventually without it even bothering them or thinking about it. You know, how can Dr. Brown and I have shared a patient for years who has, he was in an automobile accident and he's had 37 plus surgeries. He also has Huntington's disease. And he has to take opiates. He goes to AA. He works a heck of a program. He's been sober about 13 years now, and I see him quite regularly. How does he, a lot of people will say, well, how do you use opiates and consider yourself to be sober? And he talks very openly about that in AA, talks about it with his sponsor, but he does things that allows him to not abuse the opiates and continue to work his recovery program and not go back to drinking. And Dr. Brown and I have talked about, is there any way we could ever get him off of the opiates completely? And the feeling about that is he just will never be able to do that. His quality of life would not be good enough that he could live, really. Next one is we encourage engagement with pharmacotherapy. We believe in the use of medications. There are certain medications, I'm going to mention them later, that we absolutely do not want our patients on. But there are some facilities that say we're not going to prescribe certain medications like psychotropic medications. We're not going to prescribe SSRIs. We're not going to prescribe mood stabilizers. And that's certainly okay, but what we found is that the outcomes using those types of medications, as Dr. Brown alluded to earlier, it provides that mood stabilization. That irritability goes away often. In AA, there's a phrase about whenever we're thinking about drinking, there's a lot of things we can check, but one of the things we talk about being restless, irritable, and discontent. And we check on that. Well, we watch a lot of people when their mood becomes more stable and they've been sober for a while, that they're much less irritable. You're actually able to talk to them, and it's amazing. They have this perception that the longer they stay sober, the more everyone else changes. You know? And really what it is, it's them. They're changing. Okay? And it is necessary to treat any of the additional comorbid psychiatric disorders. If we don't do that, our likelihood of that person tolerating, continuing to be depressed, continuing to be anxious, the probability of them staying sober goes down significantly. Why do we treat addiction differently than other diseases? We talk about this, and this is a simple distinction that we make. We talk about it being a physical compulsion and a mental obsession. And that physical compulsion to use often comes, people use this word. I've been sober for 3 weeks, but God, I wanted to drink today. And people often use what word when they're describing that thought process? I'm having a craving. In the field of addictions work for me, we do not talk about that as a craving. We talk about that as being the mental obsession, because the craving process, once that occurs quickly after we stop using the chemical. Okay? And once I'm really finished detoxing, that physical compulsion is pretty much gone. The thought processes that occur and all the brain stuff going on after that, we really think of that as the ongoing mental obsession to want to use. Okay, does that make sense? Okay, all right. There are incredible denial processes. Again, we've alluded to it. Minimizing, rationalizing, intellectualizing, and blaming is the way I talk about them to my patients. I get them, I'll do some things at the end, but my patients really get into this. I'll give you some examples. My friend, Dr. Gligorovic, he likes to drink. In fact, he'll drink a 12-pack a day when he gets off work. I only drink about 8 or 9 beers a day. If he's not an alcoholic, there is no possible way I'm an alcoholic. That make sense? There you go. Okay, that's a form of that rationalizing. They're mixed in minimizing, rationalizing. Here's another one. If you had to live with my wife, yeah, you'd drink, wouldn't you, Ben? Absolutely. Okay. We very strongly work toward this idea that we do not drink or use over external circumstances. Okay? And when we watch people start getting sober, they stop saying things like, well, the reason I drank is because my wife was a bitch. Or the reason I drank is because my boss, Dr. Gligorovic, is just an ass. Okay? We stop doing that because we understand that those external circumstances do not cause us to drink. What we end up focusing on is what is it that about me and my emotional processes that I have to fix in order to stay sober. As long as it's something external, we often believe that I can't fix that. Okay? Let me move on. I'll probably run out of time. We do family programming. Lots of programs often do not do family programming, but we look at it as a systems process. And we get family members in, and do you know what the most common response or acknowledgement of having this thought process is from family members when we say to them, we would love for you to come to our family programs on Monday night? What do you think is the first thought that often goes through their heads? Yeah. Some person on your row, Ben, said that. Okay. I'm not the one with a problem. If they'll just quit drinking or using, we'll be okay. And they will acknowledge. I always ask that. I'm like, how many of you are courageous enough to raise your hand and admit that? Some of them do, and that's wonderful. We can move. We can go from there. Family members often believe this. If they just stop drinking or using, the problem is fixed. Yeah? I remember one of my professors, instructors in school who was supposed to be here, and he's not here. He walked into class the first day of my addictions treatment, and he had his cowboy boots on and his big belt buckle on, and his hair was a little long down on his shoulders. And he said, how many of y'all think if an alcoholic quits drinking, the problem is fixed? I raised my hand like an idiot. I shouldn't have done that, but anyway. I remember this. I can remember growing up, my grandfather was an alcoholic. I remember my mother saying this, well, if he would just quit drinking, everything would be okay. It took me a while, even working in the addictions field, to come to understand once again that the use of the chemical is just a symptom. If we take care of becoming abstinent, then we have a chance to get everything else going. But if we don't get that going, we don't have a great chance. Oh, what did I do? There we go. Thank you. All right. This diminished capacity, addiction defies logic. Dr. Brown, again, he must have read my lecture. I don't know what he's doing, but how many of you all have had an experience where something happens in your family, or maybe it happens with a patient, and you say, why in the world would they do that? And you spend a lot of time trying to make sense of that. Okay? Is that how long I have? An hour and 15 minutes. I got to move. Anyway, the point I'm trying to make is you have this person who says, what they're saying in their head, my drinking and using is not my problem. That's my solution. And you're talking to me about stopping that? You're crazy. Okay? And all these thought processes, and as addiction people or lay people or family members, we try to make sense of why our loved ones do that. Why do you do that stuff? If my wife told me, if you do that again, I'm going to take the kid and leave you, and I look at her and I say, baby, I love you, I love our child more than anything in the world, I will never use again. And the next weekend I go out and use, and I come home and she says, why did you do that? And my answer is, I don't know. And in reality, I'm not lying. I'm telling the truth. I cannot give you a logical explanation for why I continue to do this. It's not because I'm bad, it's because I'm sick. Okay. Dr. G's making me hurry. Okay. So I want to talk about this. When we're simply a user, we're not abusing, we're not addicted, the use of the chemicals never create negative consequences for us. And the use of that chemical is typically always fun. Okay? We watch people do that all the time. Now, how many of you I'm sure most of you in here have never consumed alcohol, but how many of you early in your drinking career had an experience where you drank a lot, you got sick, you started throwing up, you hugged the commode, and you promised to God if he'd get you over it, you'd never do it again? Okay, I'm going to take that as an affirmative. Nobody's raising their hand, okay? That's an experience that for people who don't begin that process of addiction, what don't they do again real soon? They don't repeat that behavior again real soon. But even early in addiction processes, we'll watch some people that if they repeat that behavior very quickly again, to us, that's an indication that they are showing some really high-risk behaviors at the very beginning of their chemical use. We have misuse, and this is an easy example. College students, I'm drinking, I'm binge drinking on the weekends. I begin to develop sun tolerance. Instead of having 2 or 3 beers, I'm drinking 5 or 6. First time I ever heard that thing about what's a binge, how do you define a binge drinking episode? And it's for males, adult males, it's 5 12-ounce beers in an episode. First time I heard that, I'm like, well, hell, why would you start drinking if that was all you were going to drink? You know? How many of you, when you were in college and you went out, you thought, 2 or 3 or 4 or 5 beers, I'm going to drink more than that. Okay? We anticipate the effects of the drug. We have state-dependent learning, meaning I begin to associate, really, if I'm doing this, then the chemical use is going to be there too. So I begin to experience this process of I'm using at the same time that I'm engaging in these activities, and I begin to expect a certain effect and outcome. And the last one here is negative consequences become more likely. Like I might not be able to get up on Monday morning and go to class, and I miss my classes, and I make a C in that class rather. But it's not because of my drinking. It's because I don't like that class, and I don't want to get up and go to it on Monday morning. Okay. Next one. When we move into abuse, we begin to have our first negative consequences. I always give the example. It's probably too long. My wife and I met 10 years ago. I drank and smoked weed then. She didn't like weed, so I quit smoking weed, but I've always had 2 or 3 drinks. We got married 2 years later. For the past 8 years, I come home every evening and I have a few drinks. But for the past 9 months, I've been coming home, instead of having 2 or 3 beers, I'm having 4 or 5 or 6. And I come home one day and my wife says, honey, this is getting old, as I go to get a beer. And I look at her and I say, what are you talking about? She says, you coming home and drinking. And I say to her, honey, I've always drank. And she said, yeah, you used to have a couple, but now you're drinking this much. You don't help cook supper, you fall asleep, you get up and come to bed, and you go to work the next morning. Okay? And in my head, 1 or 2 things are going to happen. One is, you're right, I am. And I will modify that behavior without any real thought or problem. I stop doing that. I go back to drinking 2 beers. Here's the other thought process. And my patients have instructed me that I have to say it this way. Thinking this in my head. Damn, she's a bitch. You got to get these words out. I'm a grown-ass man. Okay? I am not, I ain't hurting no one. I deserve to be able to drink a little bit. I got a tough job. It caused me a lot of stress. Okay, so that thought process occurs. At that point, what's happened is I've made a decision that I'm going to start trying to practice control. And that control is not about quitting. It's about how I can continue to use without there being any consequences. So here's a couple of solutions. I know what I'm going to do. I work about 15 miles from home. I can stop at Sheetz, buy me a 40-ounce, and drink that sucker on the way home. And then I'll get in and I'll have 2 12-ounce beers. How many drinks does my wife see me having? Yeah. And I have to make sure that I get to the refrigerator and get the beer open before I give her a kiss. Got that? Okay. Here's another one. I work a mile from home, and I can't drink a 40-ounce in a mile, and I'm not going to drive around with an open container. Dang. So what I'll do is I'll get me a pint of vodka, keep it in the car, and I'll take me 3 or 4 hard pulls off that before I leave the parking lot at work. Or maybe I do it when I get in the garage and my wife can't see me. I walk in the house and I pop open a beer really quick. And I have 2 beers. My wife sees me having 2. No problem. Here's another one real fast. My wife's a little dumb. She's not the brightest person in the world. So. Okay, I have to give a disclaimer. My wife's a wonderful person. We've been married 27 years, so I hope it's a little longer. So, she's never really drank alcohol, so I buy me a fifth, I put it in the cabinet, I come in, I get a glass about so big and about that tall, and I pour about that much vodka in it, and then I pour the rest full of Coke or whatever, and she sees me having how many drinks? 1 drink. I could go on and on. It's hard for me to drink around her, so I'm going to go to my physician and tell him I got a lot of stress going on, and I feel like I'm drinking more than I should. And my physician, who's a friend of mine, looks at me and says, well, Dean, his thought process is if I can decrease your anxiety, maybe you won't want to drink as much, so he will prescribe me what? A benzodiazepine. Okay? I'm probably going to drink on top of that, for sure, you know that. Okay, I have to move on. And then we begin this emotional manipulation process, and that's basically I begin to use as a way of just trying to make myself feel comfortable. And where I'm going to go with this is I begin to equate feeling numb with feeling good. Okay? If there's an absence of pain, that is good. I stole that from a guy named Father Martin, who's long deceased, but he was an incredible icon in the field of addictions work. When we move into addiction, this does not come out of the DSM. This is kind of Deanism stuff, and I talk about it this way. But I call it the ends. It becomes normal to use. To not be using would be abnormal. I've had lots of men get this more often. I'll say, have you ever tried to quit drinking? And they throw themselves under the bus. They'll say, oh, shit, I've quit drinking a bunch of times. Here's the catch. People who don't have the process going on, they never think about quitting to begin with. And when they just told me they'd quit a bunch of times, what they're really telling me is there's been problems that have gone on that have brought them to the point of saying, I'm going to quit. By gosh, I'll quit for a month to show you I don't have a problem. Okay? And I'll say, did your wife comment on your not drinking? And oh yeah, she asked me why I wasn't drinking. It was so abnormal to see them not drinking. Okay, my use is not about fun anymore. It's simply about not. Let me give an example. A friend of mine says, I drank all the fun liquor a long time before I quit drinking. Okay. And he started out with pills and went through crack and some meth and all kinds of stuff. And his last year of using, 10 years of using, was alcohol. And he looked at a young man one night who said, I'm young. I'm never going to have a good time again if I quit using. And he looked at the young man and said, well, I drank up all the fun liquor a long time before I quit drinking. And he gave these examples. I would find myself driving to the liquor store in tears. I was so sick of driving to the liquor store. But I could not do it. I was sick of the game of trying to sneak alcohol in the house and hide it from my wife. And he can tell elaborate stories of how he tried to do all this stuff. You know, I was sick of seeing the pain in my wife and kids' eyes when they caught me and knew I was drinking again. But I could not stop because drinking was my solution. It wasn't my problem. Okay? Let's see. Normal to use. Feeling numb. I'm going to have to move on. What's the difference? This is inverted, where it says pickle and cucumber. One of my colleagues, who's much better on the computer than I am, he helped put this together. Neither one of us caught it. But in AA, this is one of those little phrases. It's once a cucumber turns into a pickle, it can never go back to being a cucumber. So this is inverted. It should say cucumber up on the one side. Once I cross that line into addiction and I have those changes in my brain at the level of the neurons, that goes to that saying that we do not know how to cure you. I may be a grateful, recovered alcoholic, okay? But that does not mean if I go back to drinking, I'll be able to control it again. If I'm a true alcoholic or addict, there will eventually be another loss of control. I'll finish this up. We talk about this whole person approach. If I get physically sober and I do nothing else, in AA, there's a phrase, y'all know what the phrase is? If I get physically sober, mentally, emotionally, and spiritually, I'm still acting as if I'm drinking. It's dry drunk. Dry drunk. I'm on a dry drunk. And again, getting physically sober doesn't really fix the process. It's until we start watching this other stuff happen. I say this is another Deanism. I think that the emotional process of sobriety is about 80% of the fight. And then when I watch people become spiritually fit, and I'm not relating this to religion, it can be related to that if they want it to, but I watch people become spiritually fit. And what I see in those people is I watch them walk in the rooms and they are able to accept other people where they are. They are able to stop being so judgmental. They are able to stop being so angry, and they are reaching out and helping other people. That's when I watch the spiritual recovery really going on. Medications, I'm not going to spend time on this. Dr. Brown talked a lot about this. These are the medications that we want our patients to not be on, with benzodiazepines being first. Of course, when we have people come in and they're on buprenorphine, we want them off of opiates, but we'll put them on the buprenorphine. We have a lot, I get a lot of people from the Board of Nursing, nurses. We used to get some physicians. I occasionally get some people from the dental board. But a lot of those people choose not to go on buprenorphine, and they just go through the process of coming off of it. And most of them are successful. And part of the reason I believe they're so successful is they're forced into treatment, but the other is they're so highly monitored. And that's a big determining factor in their long-going sobriety. Move on through this. The model of treatment that is most commonly used is called the Minnesota model. Are any of y'all famous with facility? It's terribly hot in here. Can anybody ask them to turn the AC down or whatever? Okay. The Minnesota model was developed at a place called Hazelden in the Twin Cities. It's probably they own the Betty Ford Centers now. It's probably the most well-known treatment model, but these are the characteristics. They do individual and group therapy, psychoeducational stuff, and 12-step meetings are an integral part of that. They also do family programming, but the hallmark of their model is primarily we get you involved in 12-step processes. What we teach you, the knowledge we give you, does not keep you sober. It's that ongoing recovery process. Okay. Closing down with this, some mistaken beliefs about relapse, stopping the chemicals, the primary purpose of treatment. That's an initial purpose of treatment. If I just get people sober, I now have a chance to help them get better. Does that make sense? Okay. All right. Once a person understands why they drink, it's not difficult to stay sober. Lots of people, none of y'all are in this category, but really intellectual, smart people. So, well, I didn't get much of a laugh on that. I insulted you all like Dr. Brown insulted the nurses. I'm sorry, Tom. You can leave before they all get out. So, all right. I watch my people that are really smart and really intellectual. They struggle with sobriety a lot of times. They want to figure this thing out. If I'm smart enough, I can figure out how to beat this. And I often watch them not get any of that other stuff. They don't understand the emotional processes of sobriety or the spiritual processes of sobriety. If I quit drinking or using, the problems in my life go away. Very often, when people stop using, we watch their problems get worse, particularly where? At home. And they're surprised. In treatment, they'll teach me how to successfully control my use. Regularly get people calling me and wanting to know if we can teach them how to drink normally. I usually don't get calls from people saying, can you teach me how to smoke crack normally? I don't get that one. But I get the alcohol stuff regularly. So one of the evidence-based modern addiction treatment outlined by the Federal Substance Abuse and Mental Health Services is 12 steps. It's amazing how much flack 12-step programs get. They don't really have people representing them, but again, you heard my prejudice early on. I really believe in that. These are the 12 steps. Okay? The first three, I won't go into all of this, but steps 4 and 5 are some of the most difficult steps to do, and that's where it requires a really strong inventory. You get down to steps 8 and 9, as a result of doing some of the other steps, you start making amends to people, and then 11 and 12, you start carrying the message forth to others. Objection to 12-step programs, I'm just going to use willpower. A lot of people get into AA's religion. I've been to an AA meeting and they use words like God. God as I understand him. AA's a cult. I had a patient one night say, I went to an AA meeting. It's a cult. And I said, you're absolutely right. You know, and I was fortunate to do a lecture about therapeutic versus non-therapeutic cults. And AA is absolutely one of those therapeutic cults. Okay? I'm different than those people. I'm too young. If I get sober, how am I ever going to have fun again? Barriers to treatment, usually money, employment conflicts. Though I will say this, I've seldom had a problem with an employer allowing someone to come to treatment, particularly if that individual is comfortable enough to ask us, can you write me a note? I cannot think of a time I've had an employer say you can't do that. Ambivalence about being sober, co-occurring psychiatric disorders, privacy concerns. At Wake Forest, there were privacy concerns about our employees coming into our treatment programs, and we had to earn that trust over several years because we'd get referrals from EAP and different things, and we have wonderful relationships now. Let's move on. This last thing, my patients one night years ago, none of you have heard of a guy named Jeff Foxworthy, right? Ben's from Wilkes County, okay? And you've heard the one, you might be a redneck if, okay? Right, Ben? You know, I don't know why Tom Brown was picking on Wilkes County people. I'm from Wilkes County too, okay? How it occurred, I don't really know, but by the end of it, we were all laughing hysterically, and it was an incredibly powerful therapeutic group because my patients were telling on themselves and laughing about it. Not in a way that they were blowing it off, that it was unimportant. They were comfortable enough to realize this is part of my insane thinking. So you might be an alcoholic if they know you by name when you walk in the liquor store. Okay, you go to different liquor stores on different days because they get to know you at each one and you're too embarrassed to go to the same one. You think alcohol abuse is leaving a drink unfinished. I had a patient, he said, I would go to parties and people would sit down half a drink, and he said, it would piss me off to no end. You know? Yeah. You throw empty bottles or cans away in a receptacle other than your own. A friend of mine, she's been sober about 11 years, and she said, one morning I was carrying my recycling bin down to the road. It was full of wine bottles, and I thought in my head, did I have a party? And I said to her, well, if you had a party and you don't remember, you probably had a blackout, okay? and then she said, I realized I hadn't had a party. These were all my bottles. And she decided to get help, and she's now been sober. She got treatment and got sober. I had another patient who would throw bottles over the fence in his backyard into the creek. And he would talk about the sense of relief he would have every time it would become a downpour like during the summer. In his head, he imagined that the bottles had all been washed away, okay? You're still drinking when everyone else is finished. That's a big one. Like in college, I have a lot of people say, oh yeah, I was a big man because I could outdrink all my buddies. That was one of those early symptoms that most people aren't aware of. You've ever quit in order to prove you didn't have a problem? I'll prove to you I don't have a problem, I'll quit. Bam, you're already caught. You've ever tried to control your using? I'll cut down, I'll change what I do. Had a patient years ago, if I'm boring you, I'll sit down in a second, but had a patient at the detox center. I walk in one morning. It's my job to assess anybody who's been admitted. He's got the shakes going on so bad he cannot drink this stuff we give him. He's shaking. I look in his chart. He's drinking a case of beer a day. I take him back to my office. We do small talk, being good old boys. And finally I said, so Mr. Jones, how long have you been an alcoholic? He looked at me. He said, I ain't no damn alcoholic. And I apologized. I said, I'm sorry, I didn't mean to offend you, but it says here in your record you're drinking a case of beer a day. He said, you can't be an alcoholic if you just drink beer, and I quit drinking liquor a long time ago. And I said, well, why did you quit drinking liquor? He said, oh, when I drink liquor, I get mean and get locked up. So the solution to his problem was, if I don't get locked up when I drink beer, beer's good. Okay? And again, that defies that logic. Get that, Ben? You quit drinking liquor a long time ago, didn't you? Okay. Let's see. Last one there. You have ever looked through someone's medicine cabinet when you're in their bathroom at their house to see what's in there? You've ever called in for early refills because your dog ate your medicine? You accidentally washed it in the washer and all that kind of stuff. I had a patient one time that said I would take my dog to the vet and talk about how anxious my dog was and tearing up the house. And the vet only wanted to give my dog Prozac. I wanted him to give him puppy Valium, you know. And he said the vet would give that, and I would take it. You've ever cut down on one chemical only to increase of another chemical? Quit drinking so much, but I end up smoking more weed. We call that the marijuana maintenance program. You've ever explained in detail to your physician, and I teach this when I lecture to the students at Wake. If you ever have a patient that sits there and says, well, I'm allergic to Percocet, and I'm allergic to, on and on. But the thing that really works for me is Dilaudid. And I had that experience in the emergency room. I was in the emergency room at 2 in the morning with kidney stones, and there was a young lady on the other side of the magic curtain that no sound can travel through. And she was working the doc for all she was worth. And he left and came back, and he said, Miss So-and-so, I've looked at the database, and you were at this place yesterday, and you were at this place, so at such and such, and you've been prescribed this and this and this and this. And he said, we want to take excellent care of you, but I need to tell you we're not going to be prescribing any opiates to you. Guess what happened? She was magically cured and left. And on one hand, that's funny, but on the other, I'm sitting there thinking, this young lady is really, really sick. Yeah. Is our next speaker here? Okay, I'm sorry. All right. And you take notes when you're talking on the phone because you won't remember the conversation you had the next day. I could go on and on and on with these. So where I want to close this down is does anyone have any questions real quick? I spoke longer than I was supposed to. No questions? Okay.
You guys will all get updates once when the recordings of his lecture go to his wife about them.
Okay. Say this one more time. I know most of you are there any clinicians that work directly with substance abuse patients? I'm going to say this to you once again, though it is frustrating and at times discouraging. And I have a nephew who died 15 months ago from an opiate overdose. It was like a child to me. He was my favorite. It is truly an honor and a privilege to do this kind of work. And we have to remember that. Okay? Thank you all. Yeah.